Good morning, it's August 11, 2022. We're performing a Deuk laser disc repair on a patient with two herniated discs, one at C5-C6, one at C6-C7. And he has what's called DISH, which is diffuse idiopathic skeletal hyperostosis at C5-C6. Pretty bad in the front, not in the back, just in the front. And we see that a lot. There's usually some calcium deposit shot up front we've got to get through. And we've done that at C5-6. And I want to make sure we're still in the disc space at C5-6. So we're going to do a little dye shot. Hard to say. Shot. Yeah. So I'm going to try and redirect this dilator by putting the tube down and then basically redirecting the dilator. So it's a little trick. I'm going to put the tube down to give it additional support because the dilator itself is strong, but it's a little bit flimsy. But if you add the tube to it, you're going to get a more stiff and rigid tool that you can aim better with. Shot? All right, so you can see the tube is at the front of the disc. We're right in the midline. And we're parallel to we're right at the superior end plate of C6, I apologize, C6. So we're gonna go in there and I'm gonna bring the tube in halfway into the disc. If you look at the AP view, you'll see we're pretty much in the midline, which is good. That's better. We're coming in right above at the bottom of the C5-6 disc. See the bone spur there in the front? What? What? Actually, that looks a lot better. I mean, my God, Jordan, that's really nice, actually. You can see that the dilator is actually in the disc space. It's underneath the end plate of C5. And show them where C2 is. C2 is there, then count 3, 4. You on the x-ray there, Kenry?
Yeah.
And then show them 6. Perfect. Show them the esophageal probe. Yes. Show them the endotracheal tube. Yes. All right, perfect. Let's just stay with this. I think we're a bit overexposed. That was the only issue. Shot? That's better. Our patient has, why are we doing this surgery? Some of you may be wondering, what's going on here? You give me a pull? And the answer is the patient has herniated disc at C5-6 and C6-7. The herniation is in the back of the disc. Can you show them the herniation there, Jordan? Yeah, there's herniation back there. And it's the herniation that's pushing on his nerve in his arm and that's causing his arm symptoms in his left arm. So that's what we're mainly here to fix today. We also want to get rid of his neck pain, but I feel he has some facet pain, which will need an additional treatment besides the laser surgery for that neck pain. All right, that was good. Let's see where we are. So a little bit further. Now this is definitely not an easy case, okay? This is one of the harder ones. His neck is thick, he's short, he's got really bad DISH or diffuse idiopathic skeletal hyperostosis in the front of the spine. But we've had that before. We got through it. We're near the back of the disc now. I'm going to see where we are endoscopically, see what we need to do. So we're fixing two herniated discs, C5-6, C6-7 today, in a patient with neck pain from the herniated disc as well as left arm pain, weakness, numbness. We call it radiculopathy. Thank you, Luis. Luis ate his Wheaties this morning. I'm probably going to have to redirect this tube a little bit because the osteophytes in the front of the spine are kind of pushing the tube up at the back. So let's see what we've got and we'll see what we need to do. All right, if you have questions during the surgery, feel free to write them on our chat box. We're broadcasting on Facebook and Twitter, YouTube, and LinkedIn. You can see the patient's face is here. And this is the right side of his neck. His chest is here. Do you see all this, Henry?
Yeah, we see it.
All right. The whole surgery is being done with a 4mm tube. This patient doesn't want fusion. He's trying to avoid having a fusion, and this surgery that we're doing is really his only hope of avoiding a fusion or an artificial disc. Artificial discs are quite invasive as well. Are we on the pump? This is not the pump, is it?
No, this is ours.
This is ours, because I can see it's got better pressure. All right, so we're going to switch to the endoscopic view. You can see some material, disc material. I'm going to have to zoom in a little bit. A lot of bone spur. We're used to dealing with bone spurs. The laser doesn't have any problem removing bone spur. Yep.
Thank you very much.
This patient has a big chest, which is pushing against my laser. There's the herniation right there. The laser's touching the herniation. You can see it, and there's bone spur right here. Okay, so we're just going to have to take our time and remove this herniation. And as I do that, you'll see the movement of the bones gets better and better. Okay? What I mean by that is, right now, I can't move this tube very well. But once I start removing this herniation right here, it'll get better. Now this is pretty scarred herniation, so indicating there's been a lot of inflammation going on. That's bone spur there. You can see the gold color. And again, the laser doesn't have a problem removing bone spurs. And we don't go after huge bone spurs with the laser, but we go after smaller ones and medium size. Now you're starting to see a little bit of movement. A lot of this is calcified. So his left arm weakness and numbness is coming from the involvement of the left neural foramen at C5-6 and C6-7. And by the way, you're starting to see some movement. You see that? Those are the C5 and C6 vertebral bodies. And right there, you see that? The laser will release the herniation, and then we'll hopefully float it out or pull it out. One way or the other, we'll get it out. Oh, there we go. There's a nice piece of herniation right there. The name of the surgery or disc repair was found to be safe and effective for the treatment of symptomatic disc disease. And at the time, we published with the cervical spine, but we've also published with the lumbar spine or lower back. And as a matter of fact, probably the most important paper we published was the lumbar long-term outcomes, which was around 200 plus patients with over sorry, I'm just focusing here, over 6 years, on average, 6 years of follow-up. So it's a long-term outcome study where we had a minimum of 5 years, so no patient without at least 5 years of follow-up, they couldn't be included. So you had to have at least 5 years since your surgery, your Deuk laser disc repair. And we found that the average was 6 years for the group. And the outcome was 92% elimination of back pain still. There's herniation right there coming out. So people ask me, Dr. Deuk, when you're done, is this disc going to be normal? The answer is no. The discs are never, never, never normal. Once you've injured your disc, it's never going to be normal, no matter what surgery is done. If you get an MRI done afterwards or a CAT scan, you won't see a normal disc, okay? Our goal is not to have a normal disc, because if that's the goal, we wouldn't even do surgery. Our goal is to get rid of the patient's symptoms and make them feeling better. You know, get rid of their arm weakness, numbness, and get rid of their neck pain, headaches from the neck if they have them. That's the goal of surgery, okay? Not to make the disc normal. Only God can make the disc normal. Normal looking on an MRI. We can make it normal feeling, we can't make it normal looking. MRIs have nothing to do with feeling. They have to do with looks. When you take a picture of somebody, you can see what they look like, but you can't see what they feel like. And MRIs are like that. They're basically a picture of of the inside of the body, but the disc as far as an outward representation without knowing how it feels. All right, a lot of scar tissue from inflammation, bone spurs. But so far, everything is going well. We're in the first of 2 discs that we'll be fixing. And again, it's hard because his neck is pretty thick and his chest is big and barrel, and it's kind of pushing my hand away from him, so it makes it harder. And then he also has broad shoulders, which make it harder to see on x-ray. But you can see back here, we're now at the back of the disc. There's no more herniation there. I just need to work my way to the sides. And I'm starting to do that gradually, side to side, a little bit at a time. These are all pieces of herniated disc. A lot more movement we're seeing. One of the nice things about this procedure is we don't fuse, so there's no loss of movement. And we're still able to achieve the goals of surgery, which is, to remove the herniation and debride the annular tear. So, Henry, would you mind showing our audience what is an annular tear and how the annular tear causes pain and symptoms with the herniation?
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. Hopefully you've had an opportunity to understand a little better about what causes neck pain with a herniated disc. It's actually inflammation coming from a tear actually in the back of the disc, and that tear gets jelly or nucleus stuck in it, and when that happens it creates inflammation. The inflammation then can spread to the nerves, the nerve roots, and cause arm symptoms, or it can spread to the dura and cause headaches. So look at that, there's another piece of herniation right there. I'm going to try to grab it out. Oh, I don't like that stickiness there. I don't know. I feel myself tugging on it, but it doesn't want to come out. There we go. Look at this. Look at this herniation. Turn the light on.
Lights on, please.
Take a look at this here, and this, Henry, can you see it?
Yeah.
Look at the size of that thing. Can you see it?
Yeah, we see it.
That is a big piece of herniation right there. So, just to give you an idea, it's bigger than the tube it came out of. So, here's the scope, all right? you could see the laser fiber right there, right? See how skinny it is?
Yeah, we
That's
see.
half a millimeter. This is 3 millimeters, the endoscope, and then you can see how big this herniation is. It's huge. It's probably around 5 millimeters, 6 millimeters. All right, let's get the lights off and let's go back in. Yeah, so the surgery is just about a process of just removing one piece of herniation after the other. And we don't have an exact number, but you know, through all the years of doing this, I think that the average herniated disc has around 30 pieces of herniation. Laser, please, laser. So, you know, you can't just go in there and take one piece out and say, hey, we're done. You gotta get them all, as many as you can, safely out. All right. Here's more herniation. There's some bone spur right there. Now this is his left foramen. I'm gonna pull my tube back a little bit just so I can get a little bit more lateral. Now the nice thing about this scope that I'm using is it's flexible. There's the foramen. It's flexible because it's a fiber optic scope. Now rod lens scopes are not flexible, and rod lens scopes will break if you flex them. That's why I like this scope better. You know, the company that made it tried to get me to switch to a different kind of scope, and I said no. And they're not happy with me. But again, everything we use is FDA approved 100%. We don't use anything non-FDA approved. We've also converted our operating rooms to be latex free because so many people have an allergy to latex. This is all scar tissue. Now we just did one of these surgeries 2 days ago on a patient who came from across the state. She's from she's up in actually Daytona area, I believe. So she's further north. And she had a Deuk laser disc repair, cervical spine, and you're gonna have her visit, right, soon? Henry, her testimonial?
Yeah.
Yeah, she was very happy. Her neck pain was gone right afterwards. Her arms were weak before surgery. They were 100% back to normal. It was a wonderful result for her. She was very happy. She actually drives buses and for the school district, and she's not back to driving a bus, but she went back to work the morning after surgery. Literally, she showed up for her post-operative appointment the next day in her outfit for work, which is a bus driver's outfit. I just thought it was amazing, you know. People are able to get back to their job literally the next day if they want to. All right, this is a tough foramen. There's a lot of scar tissue, and there's a big herniation right there. Let me get that one out. So take a look here, Henry. Turn the light on a second.
Lights on, please. Thank you.
To get those, can you see this, Henry? To get those herniations, we use a long, skinny grabber.
Yeah, we see it.
It's about 3 millimeter, not quite 3 millimeters, maybe 2.5 millimeter wide. And I just go down there and I grab those pieces out, usually. There we go. Now you see how much smaller that one is than the last one. Here you go. But we call this in medical terminology and surgical terminology, we call it piecemeal removal, piecemeal, because you're removing something in pieces. So it's called a piecemeal removal. All right. Let's get back in.
Thank you.
Okay. So far, so good. You can see there's a lot of inflammation. These are bone spurs right here. I'm removing bone spurs. There's still some herniation there. We're going to have to get it out. Some bone spurs right there. Yeah, people think, oh, if you have bone spurs, the laser won't work. That's not true. The laser works far better than any other tool in medicine for spine surgery, especially endoscopic surgery. You can't do surgery without these endoscopic surgery without a laser. It's impossible. Doing all right?
Me?
Yeah.
Yes, thank you.
Any questions from the audience?
No current questions yet.
All right, audience, you got to do your part. You got to ask questions. There's all pieces of herniation right there. You see those?
Yeah, we see them.
Folks, feel free to ask a question. The reason we do a live stream is so you can ask questions. So don't be shy. Don't be bashful. Let's ask questions. I'm happy to try to answer them for you. But we are literally at the back of the disc at C5-C6, and this is all pieces of herniation. And we have to break it up into smaller pieces so they can come out. Sometimes they are already small pieces, in which case they just come out. Other times we have to break them up. And that's what I'm doing here. That was a pretty big piece of herniation. I need to get a good look here. Unfortunately, the dye would not come out for this one. We tried the blue dye that we normally see. And the reason is that this is all scar tissue. This is from chronic inflammation. So this patient has a lot more scar tissue in the back of this disc than most patients, okay? And because of that, the dye won't bind to it. It won't attach to it. It only attaches to pieces of herniated nucleus. All right. I'm pretty happy. I think we're just about done. We've gotten rid of all the pieces of herniation, gotten rid of some of the bone spur that needs to be gotten rid of. This is just scar tissue here. And I'm not here to take out scar tissue. I'm here to take out herniations and bone spurs and debride the annular tear. So I'm pretty happy. I'm going to take a little bit more look over here on his left. But that's his neuroforamen down there. And I don't see much herniation left in there. Just a little piece over here. I want to get rid of them. You're watching a Deuk laser disc repair. This is endoscopic spine surgery. Unfortunately, most spine surgeons don't know how to do this surgery. This patient comes from Canada, and he traveled to Florida to get this particular surgery done because he did not want a fusion. Unfortunately, that's what most spine surgeons will offer their patients because that's all they know how to do. I've done over 1,000 cervical fusions in my career, so I definitely know how to do fusions, but this is a far better surgery for them, for the patient, and safer. We've never had a complication with this surgery. Don't plan on having one today either. Just about done on this disc, maybe another 5 minutes. It looks like there's still a piece of herniation here. A pretty good size one. I'm going to take a look, see if I can, it may be part of the annular tear right there. Just see if I can clean it out. I want to make sure the more I clean the annular tear and get rid of the herniated pieces, the faster it'll heal, the better it will heal. Yeah, no problem. Let me know when it's done. Huh? Done? Thank you. See how scar tissue is so white? One thing I've noticed with the Deuk laser disc repair patients, these patients, is that they actually have more movement in their spine after the surgery, after the procedure is done. So fusions are going to eliminate movement. Artificial discs have not been proven to really maintain or preserve. They call it motion preservation. You're preserving movement. But actually, the Deuk laser disc repair, I think, in my experience, improves the movement. All right, we're done here.
All right, eyes on, please. Scrub off, please. Thank you.
Now we have the next disc to do. We're going to put a little antiseptic to, make sure we don't get any infection. The sticker's sticking to me. Antiseptics are pretty commonly used in surgery. It's called a topical, meaning we're not injecting it in the vein or muscle. We're just putting it topically. I think that needs to be pipe cleaned. Let me have I'll do it. All right, we're good. So we're cleaning out the betadine. And betadine is a wonderful antiseptic. It's safe as long as the patient doesn't have an iodine allergy. And it's the most powerful topical antiseptic we have available in medicine. It was developed by NASA for use in space to kill any germs they may encounter with space travel. So you imagine it's covered everything on Earth: fungus, parasites, bacteria, viruses, those 4 microorganism categories, classifications, plus little green men. All right then, let's get a picture. So now we're going to have to move from this disc to the next one down. That's going to take a lot of effort from my team. We're going to have to get everything in position. We're going to get a little shoulder pull, some inline traction. And how are we doing on muscle relaxation?
Doing pretty good. Just checking.
Good. So you guys, everyone get situated, and when you're ready, let's make our attempt at this. I'm going to start by taking maybe I'll keep that in just to give me some extra leverage. All right, take care of that. Let's see if we can make it work, because he's got a very thick neck and his collarbone is literally right here. So I've got to come down up against the collarbone, which is very hard to do. All right, everyone is that our latest x-ray? All right, let's get the head in line. All right, whenever you're ready. Okay, everybody ready? All right, let's just see where we are. Jordan, yeah, we're going to need a lighter picture. Now, he had the dish at this level, 5-6, but it's not as bad at 6-7. I need to see that anterior entrance, the front entrance. It's pretty close, Jordan. If we could do a little better. It is close. It's not bad. Huh?
You're probably going to need to grab like that.
Yeah. All right. Yeah, I might need to. It's got pretty good movement. I'm going to pull the tube out first. All right, shot. Okay, tube is out. And now I'm going to bring out the dilator. Shot. Everybody ready? That looks good there, Jordan. Shot. Is that it?
That's correct.
All right, here we come. Shot. 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 Oh, that's beautiful. Shot. Just about out. Shot. Very close. Feel like I'm right on the edge. There we go. Shot. Now we got to check our AP. Just do a quick AP. Can't see. No, don't release too much. And shot. All right, not bad. Give me a better AP. I think I'm just a little off to the left. But the spine seems to be curving that way. All right, I think we're good. So let's go back to a lateral, everyone. Now the nice thing about the surgery is that we don't lose any blood. We lose a few drops. You actually lose more blood getting your blood drawn. Shot? All right, here we go. It's a bit of a bumpy road. Shot? 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 It certainly isn't easy. Shot? That feels good. Shot? Shot? That's better. Give me an AP. Wait. Give me a quick AP. Perfect. Lateral. We're almost done. Give me a mallet. There's a little scoliosis. That's perfect. Shot. Shot. It's getting worse, the picture. What can you do for me? Let me see. Give me a better shot. All right, that's better. Luis, I need you to shot. Not bad, not bad, not bad. Give me an AP. Let's just make sure we're in the middle. And by the way, folks, please don't try this at home. Let me have a rate tech. That's perfect. Oh my gosh, couldn't be better. All right, let's keep going. Give me that lateral view, everybody. I need that lateral view just one more time. Luis, get in there and give me a shoulder. Shot. Oh, it's wonderful. Oh no. My glove.
Hey, another 8.5, please. 8.5, please.
Is there any way, Coker? Everyone stay where you are. Try to pull that out just a little bit. Oh, it came out. I'm going to change it anyway. Just give me another 8.5, just to be safe. My glove got caught between the tube and the dilator. Sometimes you get a little pinch. There's no hole, but I'm going to cover it anyway with another glove, just to be safe. Wait, I can't get my fingers in. Can you pull that right there? Yeah. Yeah, now pull it in. Yeah. Not that part. All right, that's good enough for now. Leave it alone. I have an idea. Shot. That's looking pretty good. I want to shot. That's really nice. Let's get a discogram. Let me have the pipe cleaner. Everyone's doing a great job. Stick with it just for another minute. Shot. Shot. Perfect. I'm going to need another glove. Another left glove. Yeah, I got it. Shot. That should do it. I think it did it. I want another glove. Just, yeah. Shot. I need a better picture, guys. I need to see it. Maybe don't darken it as much. Lighten it up a little bit.
All right, ready?
Shot. Oh, that's nice. Shot. A little bit. Almost done. Shot. Shot. Yeah, that's fine. All right. Let's change my glove because this is not on properly. All right, any questions from our audience, Henry?
No current questions.
Let's go ahead and show our audience what the Deuk laser disc repair, how it works, what it does. Let's do an animation video.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, well, you've just watched our, but wiggle it. Yeah, you've just watched the animation. Yep, you're good. That shows you that with the Deuk laser disc repair, which is an endoscopic surgery done with a tiny tube and an endoscope. Yeah, you can pull the fluoro out. We're actually not removing the entire disc because 95% of the disc is fine. There's nothing wrong with it. We're just going to the back of the disc where the herniation is that's causing all the symptoms. And I'm using a laser to remove the pieces of herniated disc that are causing all the inflammation in the back of the disc where the tear is. And you saw that with the animation. So far we've lost 3 drops of blood. There's been no blood loss, and there's not going to be any scar tissue from the surgery except where the incision is.
Scrub off, please. Scrub off and lights off.
So the patient won't have scar tissue, won't have fusion, won't have metal. This is all natural. We're helping his body repair the disc, basically. It's kind of like when you have a thorn in your finger, a piece of wood, getting that piece of wood out, and then the body will heal. That's what we're doing. We're getting a piece of wood, but it's not really wood. It's the herniated disc. It's herniation. That allows the tear to heal. All right, you can see, again, we're in the back of the disc. Once again, we did the discogram, but there's not much staining. There's a little bit there, blue. You can see it at the laser. But the rest of this is not staining because it's all scar tissue from inflammation. You see a little bit of blue there. The blue is the herniation, and it's between the bones, the end plates at the back, herniating out into the epidural space. A little bit of bone spur at the top, a little bone spur at the bottom. Nothing we can't handle with the laser. Folks, don't believe doctors that tell you the laser doesn't work. It's only because they don't do the laser. So they're right. It wouldn't work for them. Right? Then again, flying a jet wouldn't work for me either because I don't know how to fly a jet. The point is, without the right training and equipment, you can't do things. So doctors are going to tell you that laser's not right, not a good surgery. That's because they don't have the equipment, they don't have the training, they don't have the experience. So anesthesia wouldn't work either for me if I tried doing anesthesia because I'm not an anesthesiologist. I don't have the training. It doesn't mean anesthesia is not right for someone else to do. It's just not something I've been trained to do. So surgeons that aren't trained to do this kind of surgery won't recommend it for you. The problem with that is that they're only going to recommend what they do, which is not good. It's fusions. So don't believe them. Get a second opinion. We offer a free MRI review at no cost. If you submit us your MRI, I'll look at it. I'll do an exam over the internet. and figure out what's wrong, what's causing your symptoms, and whether or not surgery is the right thing, or you should do something else. We've been doing free MRI review at Duke Spine now for several years.
No, you do it.
As a matter of fact, COVID provided the impetus because people didn't want to come to the office to be seen. So we did these telemedicine consults, and I got very good at figuring out where people's pain was coming from over the internet, out of necessity, right? Everything okay? What's going on? Who? Nausea. Can you put scopolamine patch? I need you to push the chest down. You can see all the herniated fragments coming up. Are we done with the animation?
Yeah, we've been done for a minute.
All right, so we did both animations.
Yep.
Why don't we show people what the alternative surgery that their surgeon will recommend? What does it look like? What does a ACDF fusion look like? Stand by. You have that comparison video to the endoscopic surgery.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Welcome back. We are just finishing up C6-7 herniation. I'm out in the foramen on the right side, and this is a little bit of herniation and scar tissue. You can see it right there. The laser is taking the herniation out right there. Just a little piece, not much left. We got rid of some bone spurs right there, right there. Those are all bone spurs that were interfering. These are a little bit more bone spurs in formation. We floated out some more herniated pieces, and I'm going to go back. I got 5 minutes max, doctor. 5 minutes max. I still need to get over to the other side. So we're just about done. So if you have questions, folks, feel free to type them up. I'll be happy to answer them for you. Oh yeah. It's almost like popping a zit, you know?
That's exactly what I was saying earlier, Dr. Deuk. Oh my gosh, you literally like read my mind. I said it's like satisfying. It's like
Yeah. Well, to pop a pimple, you put pressure, right? I'm putting a little bit of pressure with the tube and the laser, and it's popping the herniation right out. The blue stuff is the herniation. Oh, good. Well then, so I'm as popular as the pimple popper? Have you seen that dermatologist, the pimple popper, on TV or on the internet, whatever? She's got like millions of views. How come I can't get millions of views with laser spine surgery? I'm just kidding. I don't need millions of views to feel better. Maybe I should start popping pimples. What do you think, Henry?
That is an excellent question.
How about if we do spine surgery and then we pop a pimple at the end?
I'm all for that.
That's another
Yeah.
good size herniation. Yeah.
If the patient has
Yeah.
one, you know.
Pay for your spine surgery and we'll do a free pimple popping at the end for you. Included.
You know, one time I went to a taco, like a taco boss, like one of those food trucks.
Uh-huh.
They say, we remove your lice for free.
No way.
Yes. Yeah.
Oh my God. That's funny. It looks like our irrigation is not as good. Is it at the end? All right, I'm just having a hard time seeing. See, you think there's enough? I'll be done in 2 minutes. I mean, I don't mind if you have to switch.
So probably that's one of those difference between this pump and the other one, because the other one, the pressure is created on the tube, not on the bag. This one, then you know what I'm saying?
No.
Like
Can you push down?
yes, sir.
Oh yeah, yeah, yeah. The other one doesn't put pressure on the bag.
Correct.
Yeah.
So
No. That's why it's a peristaltic pump.
yes, yeah.
Yeah. But you think that's a bad thing or a good thing?
Well, the pressure is on the top of the bag, so
Mm.
when he's getting low, that's probably when you lose the pressure.
Oh yeah, why don't we change it? Because I got to be able to see this last part. Doc, give me a couple more minutes. Berndes. All right. Did you switch?
You switch the back? Yeah.
All right. Here we go. All right, so today at Duke Spine Institute, we'll be doing 4 surgeries. This is the first of 4. What is the next surgery?
It's a lumbar.
Lumbar. All right, lumbar DLDR, Duke laser disc repair. And she is having a couple of levels treated.
Yes.
Can we turn the light down just a little bit? It seems like it's a little over bright.
You,
I need a
no,
few more minutes, Dr. Berndes.
yeah, that one, yes.
Help me,
Yeah.
Louis. That's better.
Thank you.
Yeah. It's just. All right, just need to get a little more out here. And we'll be done.
Hey, this patient in fact you have some chest pain, don't freak out. It's just because we have been putting some pressure here and there. Just so you know.
I don't see anything more in the foramen. There is a little bone spur here, which I'll remove, and then we should be done. There's another piece right there. I think 2 minutes. Oh, come on, get out of there. right? Those are all pieces of herniation. I think that's it, Luis. I don't see anything more pushing on the nerve. That's bone spur. We got rid of it.
Luis, can I have steady street?
Yeah, we're
slow,
done.
Please? And,
Let me just check the other side real quick. Flip it. That's it. Good. Huh?
No, by grill, this one.
All right, done.
All right, lights on.
Wait, let me look right here. Give me 1 second. Just want to check this.
Thank you very much. Yep, go there, buddy.
Yeah, we're done pretty much. Let's just look at this. Hiding behind the tube. Oh, there with that. Yeah, he's just got a lot of herniation. And it's all old. It's been here for a while. Huh? There we go. All right, we're done.
Lights on, please. Go up. Thank you.
Little antiseptic. So let's show the audience here, Henry, in a moment. Can you guys see this? How small this incision is?
Yeah, we see it.
It's about 5 millimeters. I made it a little too big today. I made it 5 millimeters instead of 4. But, you know, no one's perfect. Yeah. I'll show you in just a minute how tiny this incision really is. All right. You ready? Whoops. Disconnected there. Take it. All right, so we always want to apply pressure. And the kind of bleeding we might get is from a vein. That bleeding is always around 10, 12, 15 millimeters of mercury. It's not much. You just have to put a little bit of pressure. It closes off the hole in the vein, and it lets the body make a blood clot. First a platelet plug, followed by a blood clot. And the platelet plug is really the platelets circulating in your vein. They see some of the tunica adventitia, which is connective tissue outside the endothelium. And they start to attach to the collagen and elastin, and they start to aggregate and attach to each other. As they attach, they undergo conformational change, and they become sticky to each other. Whereas normally when they're floating around in your bloodstream, they're not sticky to each other. As a matter of fact, when you get white clot syndrome, they start sticking to each other in your bloodstream, and then you get blood clots throughout your body. It's called disseminated intravascular coagulation, or DIC, and people die from that. So it's a good thing the platelets don't attach to each other normally when they're circulating. They have to be activated by attaching to a hole in the wall of the vein. And so they end up forming a plug there, and that's the first step in arresting any type of extravasation of blood out of the venous system. And then, of course, a blood clot forms with fibrous fibrinogen and fibrin, and then it seals off, and over time you epithelialize it or endothelialize it, so you repair it. So anytime doctors go through a vein or artery, they can heal those things. All right, we're done. Go. We had about, I don't know, 10 drops of blood maybe. Can you guys see the hole here?
Yeah, we see it.
The whole surgery was done with a little Band-Aid hole. All right, Luis, you want to take over? Give it another minute or two of pressure, just to be sure. And then, good job, everybody. All right, folks, type up your questions. I will be happy to answer them live for you in a few minutes. If you are interested, the Deuk Spine Institute has an app that's free, and Oh, by the way, did you put the time? The time surgeon finished? No, now. No, it's not till I walk away. So it's right now. 10:50. I think that one's 2 minutes behind. The other phone is 2 minutes ahead.
Do you want me to record when you take the scope out, or do you want me to just
No, the scope's not important. No, it's when I literally walk away from the patient. That's when I'm done. But anyway, the app is free. If you go to the App Store, type in Deuk, D-E-U-K, Spine Institute. You can find our app downloaded, and it's got a lot of useful information if you want to learn more about herniated discs or spinal stenosis or pinched nerves, radiculopathy, anything to do with the spine. I'm going to call our EBL 0.5 mil. And this was a right approach, DLDR, C5-C6 and 6-7. By the way, I'll tell you guys in the conference room in a minute when I get there his story, because his story is so familiar. I hear it all the time. He had seen a neurosurgeon, I guess somewhere in Canada or somewhere else, and they told him that the laser surgery wouldn't work for him, which how the heck could they possibly know if they don't do it, right? These doctors, they just make stuff up to keep the patient and give them a fusion so they can make their money, which is not what's best for the patient. All right, I'll be right there. Go ahead and run one of our videos for the audience. Henry?
Okay. No worries.
I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk here at the Deuk Spine Institute. I'm with one of my patients who's traveled to us from Mississippi, and he came here for the Deuk laser disc repair to be done for a herniated disc on his neck, and he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well, no problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything is gone. A little soreness in my throat. My voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4mm incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery and I decided to give it a try. And I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck on your spine.
No, I think the cold weather would have had an effect on it. I think it would have caused a Facet effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
This is Dr. Deuk. I'm here with one of my patients who underwent the Deuk laser disc repair on his neck just yesterday. How you feeling?
I'm feeling better, a lot better. Already, after years of chronic neck pain, I'm already feeling better within 24 hours.
So is the pain that you had when you came here, do you still have that pain?
Not that pain, it's just, I think, a little bit from the surgery itself, but it seems like a lot of the numbness and the tingling in my hands went away, and already starting to feel a lot better.
Now you had a fusion done before, not by me, and you can see the scar there, and then you had the laser surgery done yesterday. And how would you compare the two experiences?
Night and day. I actually, when I had the fusion, had to go back to the hospital with complications. And it just took a long time to recover from that. So this was much, much better.
Your fusion on your neck was done by a pretty famous neurosurgeon, right?
Correct.
Even with him doing it, there were still issues.
Yes.
What kind of problems did you have with the fusion?
Well, I went there for the numbness in the hand and still the chronic pain that I've had for many, many years. And it seemed to take away the numbness in my hand, but the pain was still there. So I spent many, many years going to chiropractors. I've had injections, I've had massage therapy, physical therapy, and it, most of them gave a little bit of relief.
Did any of them get rid of your pain?
Not completely, no. Just kind of made it bearable.
And is your pain gone now?
It's certainly getting there. I'm thinking probably within a week it'll all be gone.
And your surgery was done, even though you had a metal plate in your neck from your prior fusion, we were able to work around the plate and get in there and fix those discs, especially the C3-4, which was, you can see a lot of herniated disc material in there that was causing most of your symptoms. So I'm happy you're doing so well. And you had it outpatient, so you didn't even have to go to the hospital.
Correct. Yeah. Left in about an hour and a half.
What are you going to do now that we fixed your neck?
Well, I'm going to take care of it for the prescribed 6 weeks, and then hopefully I can start getting back to a normal life, be able to get back to golf and things I like to do. Dr. Deuk and his processes here and everything's amazing. If you have a lot of chronic neck pain or back pain, I would highly suggest coming to him.
Awesome. All right, my friend. Congratulations. And good morning, I'm Dr. Deuk with the Deuk Spine Institute, and you've been watching our patient who came from Canada with 2 herniated discs, the number 5, 6, and 6, 7. And let me see if I could show you. The most common disc to herniate and cause problems for patients in the neck is the number 5, 6, which he had. The second most common disc to herniate and cause problems is 6, 7. And he had 5, 6, 6, 7. The next one is C4, 5, and it's called C for cervical because the part of your spine in your neck is the cervical spine, as opposed to the lumbar, which is in the lower back. So I want to show you just this model right here, which illustrates the bones in the front of the spine called vertebral bodies, and then you've got the number 5 bone, the number 6 bone, and you've got a cushion between 5 and 6. And that cushion is allowing your spine to be flexible, bending to the side or front back, flexion extension we call it. You see that movement there? So we want to keep this movement, and surgeries like spinal fusions where the surgeon goes in and literally cleans out the disc, puts a cage in there. Can you all see that cage right there?
Yeah, we can see.
Beige. And then they put a metal plate with screws, they bolt that onto your spine. So now there's no movement. You've lost that movement forever. The rest of your life, there's no reversing a fusion. So you're stuck with the metal, you're stuck with the fusion, you're stuck with the loss of movement, you're stuck with the scar tissue from a fusion surgery. You watched that earlier on, go back and rewind it if you want. You could see how major it is, big exposure, pulling everything apart, showing the front of the spine, cleaning out the discs, putting the cages in filled with bone graft, and then the metal plate at the end. I've done 1,000 of those anterior cervical discectomy infusions. I've done 500 posterior cervical laminectomy infusions. They're really damaging surgeries because, yes, you're getting rid of that little herniation in the back of the disc, but think about all you're doing just to get there. You're making a huge incision, moving everything over, causing bleeding and scar tissue and damage to the esophagus, trachea, soft tissues, possibly carotid artery, jugular vein. And then you're literally taking the entire disc out just to get to a little piece in the back, all right? And that's why the Deuk laser disc repair and endoscopic surgery is so much better for patients, because instead of, I'm going to pull the disc out and show you, instead of just scraping the whole disc and then fusing the bones above and below, I'm literally passing through the disc with a 4mm sleeve, 4mm, and I'm getting to the back where the herniation is, and I use the laser to free up the pieces of herniation, the fragments, and I take them out piecemeal through the tube. So the tube is an evacuation chamber. It's not just giving me access to the back of the disc where the tear is and the herniation is that's causing all the problems. It also allows me to remove the herniated fragments. It allows me to bring the scope in and use the scope to see back there and use the laser. So avoid fusions, avoid artificial discs. Artificial discs are exactly the same thing as a fusion, except that there's some movement still left between the two bones. The problem is that they get loose, they fall apart, they pop out, they cause osteophytes and bone spurs to form because of the abnormal movement. So I don't do artificial discs anymore because the results are so bad when compared to the laser surgery that you just watched done. All right, we're going to take I do want to say something about this patient. So he's from Canada. He had the 2 herniated discs. We just fixed them both with the laser surgery, 4mm incision. But before he came here, he had already seen a spine surgeon who tried to convince him not to come. He said, laser surgery is not the right surgery for you. You need a fusion. And the reason these doctors say this is not because they're right, the patient needs a fusion. They're saying it because they don't want to lose the business. All right, think about that. These doctors, these surgeons would rather put a metal piece of metal in you and fuse your spine rather than send you somewhere like Deuk Spine Institute where you can get the more advanced, newer surgery that's far better. Okay? And for people who don't understand, I do fusions. I did, for 26 years, I've done cervical fusions. As a matter of fact, I'm doing one in a couple of weeks on a patient who happens to be my mom. So you're going to watch me do an ACDF in a week or two, probably I think it's 2 weeks, maybe the 23rd. That's my own mother. I can't do laser on her because her spine is slipping and twisting and totally collapsed, and she's not a candidate. So 95% of patients with herniated discs are candidates. 95% of patients with spinal stenosis are candidates for Deuk laser disc repair. If you know somebody suffering with back pain, neck pain, thoracic pain, get us their MRI scan through our website. Just go to www.mri.deukspine.com. So type into mri.deukspine.com. We do a free MRI review and consultation, and we'll let you know what's wrong as well as what needs to be done to fix the problem. If laser surgery will work for you, like the one you just saw done, then we'll recommend it. That's the top choice because there's no bleeding, no scar tissue, no complications, and it has the best results in terms of outcome for getting rid of pain in the neck and down the arm and weakness and numbness and tingling in the arm. All right, let's take our first question.
All right. The first question comes from Metro Neuro and Spine Hospital.
Metro Neuro and Spine Hospital in where? India, or is that the United States?
I think that's India. Okay.
Welcome to our broadcast, Metro Neuro and Spine Hospital. Thank you for being here. And you have a question. What's the diameter of the tube?
Yes, diameter of sleeve. Yes.
The sleeve or tube that I used, the outer diameter is 4mm. 4mm. Good question.
And we just got another question from Brian Johnson on YouTube.
Brian Johnson, welcome back.
And he asks, what do you say to the people that discogram is not a good way to diagnose pain in the back?
So Brian, great question. Brian is asking, Dr. Deuk, I hear people saying discograms are not a good way to diagnose pain in the back. So, first of all, the first thing that should always be done is a physical exam. So step one, patient needs to go to the doctor, a really good doctor, not any doctor, because most doctors will not be able to tell you where the pain comes from. Go to a good doctor. Come to Deuk Spine if you can't get one. All right, travel. It's worth it. So number one, physical exam. By looking at where the patient's main pain is on their back, I can tell where the source of the pain is almost every time. Okay, so step one, you have to have what's called a high index of suspicion. It's called a high index of suspicion. And it's a special terminology in medicine that means the doctor has a really good idea about what's going on just based on, in this case, the physical exam. Okay? So you have to have a high index of suspicion. Another example, I'll give you an example, something different. Let's say you have an 80-year-old lady. She goes to church. She has a history of osteoporosis. You see her at church. She's in horrible pain, and it's in her thoracic spine, and she's hunched over. Okay? You have a high index of suspicion that she has a fracture of her vertebral body, because that's the most likely cause. Her pain started suddenly. She has troubles with weight bearing. She's an 80-year-old female. 80-year-old females have, they're postmenopausal, so their hormones are progesterone and estrogen are off unless they're taking supplements, and their bones get weak over the years, and then they crack down. So based on the clinical presentation of the patient, the age, their risk factors, based on postmenopausal, their description of the pain, the location of the pain, you have a high index of suspicion there's a fracture. You order a scan, you find the fracture. Okay, so doctors that are really good at treating back pain, they have to have a high index of suspicion about what the cause of the pain is based on the physical exam. So that's number one. Number two, you get what's called an MRI. Okay, the MRI to me is the most valuable tool besides the physical exam that you would want to order next after the physical. So MRI, and then you look on the exam, like where is this pain? It's L4-5. You look at the MRI, what's going on at L4-5. You want to rule out a tumor, a fracture, infection. You want to rule those out with the MRI. The MRI will do that for you. Okay? What you're left with then is either going to be the disc problem or a facet joint problem. That's it. I mean, once you've eliminated fracture, tumor, infection, 99.9% of the time the pain is coming from a disc or a facet joint. Okay? So after the MRI, which will guide you, the next step, if you wanted to do a discogram, and we don't do discograms on all of our patients diagnostically, we make the diagnosis without the discogram. I use the discogram in surgery to confirm the diagnosis. So the discogram I do during surgery is necessary because I want to see the tear, I want to see the herniation, but also it confirms that that disc is the source of the patient's pain because they have concordant pain, which means that's their pain they get every day. So I ask them, is this the pain you get every day? Yes, it's concordant. If they say, no, I've never had that pain before, it's different, that's non-concordant. So yes, the discogram in the operating room can be a little bit helpful, but the main purpose is to confirm the diagnosis that I've already made. So I agree in a sense that discograms are not really necessary to make a diagnosis as to the source of pain unless the doctor has no clue what they're doing, and then they shouldn't be working you up and treating you. But the discogram is good for confirming the source of pain. All right, so I don't know if that makes sense, but I wouldn't just jump to a discogram on every patient with back pain. I'd want to do an exam, I'd want to get an MRI, and by then I'm pretty good at knowing exactly where the pain is. I may want to do a diagnostic facet block. Just to give you an idea what that is, the disc is here, the facet joints are back here, and then when your patient's pointing their back pain, they're pointing like this. You don't know if it's a facet, you don't know if it's a disc, but facet pain is characteristically lateral to the midline, and when you push on them, they hurt because they're swollen and inflamed. So as long as you're pushing and there's swelling and tenderness of the facets, then I would do a diagnostic medial branch block to rule the facets out first. Hope that answers your question. Any others?
That is it.
All right, I hope you enjoyed the surgery. Deuk Spine Institute stands by ready to help anybody with spine pain. Have a nice day.